Hello, my name is Desiree Vance, and I want to thank you for joining my presentation. Today, I will be reviewing 3 research articles that examine advanced treatments for adults with treatment-resistant major depression. Does ECT or ketamine provide better outcomes in treatment-resistant depression? An evidence-based review. Understanding the PICO question. My PICO question is, in adults with resistant major depression, does ECT, electroconvulsive therapy, compared to ketamine lead to greater improvements in depressive symptoms over a 6-week period? As a future psychiatric APRN, this topic is very important to me. Treatment-resistant depression is one of the most complex and high-risk conditions we manage. Many patients don't respond to first-line antidepressants, so understanding when to use ketamine versus ECT is essential for safe, evidence-based care. Now, the significance of the topic continued. The topic matters because treatment-resistant depression affects up to 1/3 of patients with major depression and is associated with significant disability and suicide risk. As a future provider, I will often be a part of the decision-making process around advanced treatments. It's crucial to understand the evidence comparing ECT and ketamine, so I can support patients, discuss risks and benefits, and participate in shared decision-making. These treatments also differ in side effects, accessibility, the speed of response, so knowing the evidence helps guide what may be best for each patient. Level of evidence. So in this slide, I kind of wanted to make it more of a visual representation for the treatment comparison, population, level of evidence, and strength of design. So for my first article, they reviewed ketamine versus ECT. It was outpatient in level 1 because it's a randomized control trial, and participants were randomly assigned to either IV ketamine or ECT. It was also experimental. For my second article, they looked at ketamine versus ECT as well. It was inpatient though, severe psychotic depression, also level 1, and they did a 1-to-1 random assignment. It was also open label. The third article looked at ketamine versus a placebo. It was outpatient, non-psychotic TRD, like the first article, and I believe that this article was the strongest because it was double-blinded. Also a randomized controlled trial. In this level of evidence at a glance, I just wanted you to see the key findings, which I will talk about in another slide. And I just wanted you to also have another visual representation of the design more in depth. If it was multi-site, RCT, non-inferior. And I also mentioned the key findings in the intervention and population in more detail on this slide. Now, the first study compared IV ketamine to ECT in adults with non-psychotic treatment-resistant depression. They found that ketamine was non-inferior to ECT and performed just as well in reducing depressive symptoms. Additionally, they found ketamine also caused fewer cognitive side effects. The second article examined hospitalized patients with more severe or psychotic depression, and in this study, ECT was actually superior to ketamine, and ketamine did not meet non-inferiority criteria. Concluding, for very severe or psychotic cases, ECT remains the best option. Now, the third study evaluated intranasal ketamine monotherapy in outpatient TRD. Ketamine showed rapid and significant improvement compared to placebo, with changes seen within 24 hours. So some key findings I found is, across the 3 level trials, the 3 level 1 trials, treatment effectiveness depended largely on depression, severity, and setting. ENAD found that ketamine works as well as ECT for non-psychotic outpatient TRD with fewer cognitive effects. whereas a strand showed that for more severe or psychotic inpatient depression, ECT remains clearly more effective. Lastly, the third article demonstrated that ketamine monotherapy provides rapid, significant improvement for outpatient TRD. Overall, the evidence supports a severity-based approach, using ketamine or esketamine for outpatient non-psychotic TRD and ECT for severe or psychotic cases. When comparing these studies, an important pattern emerges. For non-psychotic outpatient TRD, ketamine and esketamine are highly effective and sometimes comparable to ECT. However, for severe or psychotic inpatient depression, ECT remains the most effective treatment. All three studies are high-quality randomized trials. The genetic study has the strongest internal validity because it used the double blinding and placebo control. The other two articles were open label, which introduces some bias, but they were rigorously designed. These findings suggest that treatment selection should be based on depression severity, the presence or absence of psychosis, safety, cognitive side effects, and patient preference. Across all three studies, several gaps in evidence remain. First, all studies focus on short-term outcomes. We need long-term data on relapse, durability, and maintenance. Second, there are no direct comparisons of ketamine to IV ketamine or to ketamine to esketamine to ECT. Third, no studies look at sequencing or combination approaches, such as ketamine before ECT or vice versa. Fourth, most outcomes focus on symptom reduction, but we need more research on functional outcomes, quality of life, and cost effectiveness. Finally, we really lack evidence on which patient subgroup benefits most from each treatment. Now, based on these gaps, several research needs are clear. Future studies should follow patients longer to evaluate long-term effectiveness. We also need to practice or look for head-to-head trials comparing esketamine with ECT and with IV ketamine. Research on stepped care or combined treatment strategies is needed to see whether sequencing treatments improve or decrease outcomes. We also need more data on patient-centered outcomes like functioning, cognition, or the quality of life. Lastly, identifying predictors of treatment responses would help personalize care for patients with treatment-resistant depression. Finally, based on this literature review, here are the main clinical complications. For non-psychotic outpatient treatment-resistant depression, both IV ketamine and intranasal esketamine are evidence-based options. For severe or psychotic inpatient depression, ECT remains the most effective and should be considered first line. Regardless of the treatment, providers should use shared decision making, review risks and benefits, and monitor patients closely for cognitive and safety options. Thank you for listening. These findings support a tailored approach to treatment-resistant depression that considers severity, patient preference, and the latest evidence, and I'd be happy to answer any questions. Thank you. And here are my references. Thank you.